Hi there, I'm Richard Goldberg, Physician-in-Chief at the Ohio State University James Comprehensive Cancer Center, and I'm delighted to be talking to you from the ASCO meeting in 2015 in Chicago about some new developments in anti-angiogenesis drugs that are part of the research that's being presented at this meeting. I'm sitting with Dr. Paul Ruff, who is going to introduce himself, and we will have a conversation about our thoughts about these interesting things for investigator insights.
Thank you, Dr. Goldberg. My name is Paul Ruff. I'm the head of medical oncology at the University of Witwatersrand Medical School in Johannesburg, South Africa. And as Dr. Goldberg said, we're here to discuss interesting new developments in anti-angiogenic therapy in colorectal cancer, looking towards the future. Thank you.
So the first abstract that we'd like to discuss was presented by Peter Gibbs and talks about the SurfLocks trial. Now in this study, patients with metastatic colon cancer who were getting first-line treatment were randomized to get either yttrium injections to both lobes of the liver at the same time for a single treatment, or to chemotherapy alone. So the patients who got yttrium got chemotherapy as well as the beads. It was a large randomized phase 3 study, over 500 patients. The findings of the study are interesting. Patients on the study were allowed to have both intrahepatic disease and extrahepatic disease, although it had to be liver dominant. And what was interesting was that the hepatic disease-free survival was about 20 months in the patients who got the yttrium, but the patients who got just chemotherapy had progression in about 12 months. But unfortunately, the overall survival was no different. So Paul, how do you think that the practicing oncologist should interpret this?
Well, I think this is very intriguing data, and I think that the investigators need to be commended on doing such a large study in this area. My concerns are that they included patients who didn't have liver-only disease, and that the benefits were, from a progression-free survival point of view, were quite impressive, but overall survival isn't really benefited, and the response rate was also relatively small. So I think that we need to get more data as to looking at only liver-only disease, and also, the way of giving the SurSpheres was not conventional, giving a single shot as opposed to multiple shots. So I think that this is not really a practice-changing study yet, although it is a large phase 3 study, but I think it's very intriguing and maybe useful in the future. My other concern is that the use of internal radiation is not routinely available everywhere and may not impact on all oncologists. But I think it is something intriguing in this specific group of patients.
So we have to commend the investigators and the company for funding this important trial, and I believe that there is more to be learned from this study, and perhaps using a somewhat different group of patients could show some additional benefit here. So the next study we'd like to talk about is one presented by Jennifer Mu, and it looks at dual inhibition without chemotherapy of vascular endothelial growth factor and ANG. Would you like to talk about that?
Yeah, I think this is a very early study, but it's a very intriguing concept of having angiogenic inhibition that's not targeting VEGF, as most of the anti-angiogenic agents target VEGF. This is targeting VEGF with Bevacizumab plus angiopoietin 1 and 2 with a new agent called Prodigy. And this is in patients with very advanced disease who'd failed multiple therapies, where a response of only 15% was reported. But I think this is a very intriguing concept, and I think obviously, we have a small trial, 45 patients, a phase 2 study, and I think that we need more data with this agent or this combination of agents before we can make any practice-changing decisions. But I think what I think is probably the most exciting is that we're looking at other non-VEGF targeted angiogenesis inhibition that may become important into the future.
So the interesting thing in this, from my perspective, is the ability to use targeted agents when you run out of cytotoxic combinations, and to see response rates. Many of the drugs that we've seen used this late as single agents have had an extension of progression-free survival on the order of 1.5 months, but have really not led to responses. So I think that that's the reason that this is of some interest.
The other thing is that, data with bevacizumab in very advanced patients has really not been there. And it seems that when you're giving bevacizumab plus another anti-angiogenic agent, you are starting to get some improvement, which is also intriguing in very advanced patients. So I think this is something we need to sort of watch out for the future.
So the next study we'd like to talk about is the VELVET study, which is a study of FOLFOX plus aflibercept. This is a phase 2 trial run by the GERCOR group and was looking at previously untreated patients. And what the study showed was a relatively high response rate of about 59%, on a par of what you'd expect with other first-line agents combined with a targeted agent. Similar to the findings in the 80405 or the FIRE3 trial, showing that aflibercept is a drug that can modulate and improve the outcomes when added to combination chemotherapy. It's obviously a small study. The investigators concluded that it was worthy of further study, and so this gives us another possible pair of a combination chemotherapy regimen with a biologic. Paul, your thoughts?
Yes, I mean, this has been very interesting because aflibercept in the front line is something that we haven't seen much data on yet. And to do a study looking at aflibercept in frontline patients is intriguing. I think that it is a very potent anti-angiogenic agent, and its data up until now has been in more of a salvage role, and in fact there haven't been very convincing studies other than the VELOR trial, and so this may bring aflibercept into the frontline setting, but it's going to be difficult because the data with bevacizumab is sort of so well established. But I think this is an interesting concept. The problem, of course, is this is a very small phase 2 trial, only 49 patients. But I'm not sure whether the sponsors are going to take this any further, because in discussions in the past, they haven't been keen in taking aflibercept into the front line. So I think it'll be interesting to see what happens with aflibercept, because I've been rather disappointed that after the initial data they had in the second line setting, which was quite promising, there hasn't been much done with it. And takes a sort of independent group to go and do this sort of study. But I'm not sure how much further the manufacturers are going to develop aflibercept into the future.
So the next study we want to talk about was presented by Thomas Aparicio. It's a study called Prodigy 20, and it looked particularly at elderly patients, randomized in a phase 2 study between chemotherapy plus or minus bevacizumab. And we all have these potential concerns about the toxicity and activity of bevacizumab in the elderly patient subgroup. Paul, what did they find?
Well, they did show that the addition of bevacizumab to chemotherapy did show a PFS and overall survival benefit, albeit rather small, and there was some increased toxicity, but they did conclude that it is quite reasonable to add bevacizumab to chemotherapy in elderly patients. And in this group, they had a median age of 80, so these were elderly patients. The unusual thing, however, is that half the patients had 5-FU only, and other half had chemotherapy with oxaliplatin or irinotecan. So it's difficult to know whether the patients who benefited had if the chemotherapy played any role in their benefit. So it's again a small study with limited data. but I think it's the idea of treating elderly patients with bevacizumab-based chemotherapy is something to be considered. And obviously the AVEX trial, which used bevacizumab plus capecitabine, which was people over 70, was I think quite an important trial, and I think has shown that it is quite reasonable to treat patients with bevacizumab in the elderly setting. And I think that it's a useful combination because I think patients tolerate bevacizumab plus 5-FU-based chemotherapy quite well. I'm not so sure when you start adding the oxaliplatin and the irinotecan whether that creates a problem, but I think it's an important study because a lot of our patients with colorectal cancer are elderly, and I think it's something we need to look at quite seriously.
So I think it does allow you to individualize care, and in the off-study setting, you could start with 5-FU and bevacizumab, and if tolerance is good, then you could escalate even with a partial dose of an additional cytotoxic, and be able to manage patients so that you hopefully get the biggest benefit with tolerable toxicity.
I think a lot depends, as you say, on the individual patient, and I think that it gives us the flexibility of treating elderly patients with chemotherapy in metastatic colorectal cancer, and obviously different patients will be able to tolerate different amounts of therapy, and I think it's quite useful. I think that bevacizumab in the elderly is quite reasonable. I mean, as long as you watch the blood pressure and you make sure that there's no bleeding or wound healing, I think it's a very well-tolerated agent in the elderly patient.
I agree, and I commonly use it.
Yeah.
So the next study we want to talk about was presented by Stefano Cassino, and it's a study looking at sequencing in second and third line treatment. So the group of patients that were studied had FOLFIRI plus bevacizumab as first line. And in the second line, they were randomized to either FOLFOX followed by irinotecan and cetuximab. These were all KRAS wild type patients, or the reverse sequence. And the finding in this study was that the combination chemotherapy with FOLFOX actually led to a better outcome. The median survivals with FOLFOX followed by irinotecan cetuximab were about 18 months compared to the reverse sequence, which was about 12 months. And so I think this does support my practice bias, which is generally to use FOLFOX and FOLFIRI for first and second line treatments, and then to use EGFR targeted monoclonal antibodies in the third line setting. This is certainly not something you can be dogmatic about, but that is my general preference when I'm treating people off study. Paul, what do you do?
Yeah, I actually tend to use anti-EGFR therapy in the front line in combination usually with FOLFIRI. Use cetuximab plus FOLFIRI based on the crystal data, and go on to using bevacizumab in the second line setting. But I think that in the community environment, I think that's quite a reasonable option, is to give your Bev up front. The one thing a little bit unusual is most people, I think, give Bev with FOLFOX rather than FOLFIRI up front, and then go on to FOLFIRI second line. But I mean, I think the idea, I don't think there's really a difference going FOLFOX, FOLFIRI, or FOLFIRI, FOLFOX. I mean, there may be small differences, but so I think the idea of using sequential chemotherapy is the right thing to do. And I think it does show that you can use anti-EGFR therapy in the advanced setting, and there have been many studies that have shown that over the years, both with cetuximab and with panitumumab. So I think this is interesting. The other idea is that if you give anti-EGFR therapy very rapidly after bevacizumab, you may have less good responses, and may be better to wait into the later setting.
Next, we're going to talk about two studies that have in common the use of regorafenib. The first is presented by Dr. Chang. It's a CONCUR study that was done in Asian patients, similar to the CORRECT trial, but specifically looking at patients of Asian ethnicity. And in this study, they're looking at the quality of life and deterioration of quality of life over time Like the CORRECT study, this was a placebo-controlled trial, and basically the data shows that the quality of life did not deteriorate any more quickly, regardless of which arm the patient was randomized to. So even though there are some concerns about regorafenib toxicity, maintenance of quality of life in this group of patients was similar. The other study that we're going to talk about uses regorafenib as maintenance therapy. This study was presented by Dr. Martinelli, and it was a phase 3 randomized trial called the Revello trial in KRAS wild-type patients. Paul, do you want to talk about that trial?
Yes, look, that's still a trial in planning. So it's not been completed yet, but they're planning to look at 480 patients who've had chemotherapy with KRAS wild-type metastatic colorectal cancer, looking at the role of regorafenib as a maintenance because it's an oral therapy, which is an interesting concept. I think it'll be interesting, however, to see how quality of life is maintained in patients getting long-term therapy, because obviously the idea of maintenance study would be to keep people on this for much longer than there is on the CORRECT and CONCORD trials. So we may not be able to get this drug into patients long-term. There may obviously also be dosage issues. I mean, whether patients will tolerate 160 milligrams long-term, and there may have to be dosage adjustments if you plan to use this long-term. But the intriguing data from the CORRECT trial and the CONCORD trial is that quality of life was maintained fairly well on which was very advanced patients receiving regorafenib. And that sort of doesn't fit well with the general usage of this agent, but those in good studies with selected patients, the quality of life can be maintained. So I think the role of regorafenib may change from being a sort of end-stage salvage drug to a maintenance drug. And I think it's an intriguing concept when you can offer people something oral as a long-term maintenance. And so it'll be interesting to see what comes out of the study.
So we actually have a second-line trial of FOLFIRI plus regorafenib, where we're giving regorafenib for 7 days on, 7 days off.
Okay.
And even though it's given with chemotherapy, it's remarkably well tolerated.
At 160?
At 160.
Okay.
So tweaking the dose and schedule is something that I think will improve the acceptability of that agent as we learn to use it better and better.
I think also that if you're using it in earlier stage patients who are in better condition, the tolerability will be a lot better.
Correct.
Because at the moment we've been using it in very advanced patients.
Right.
And so bringing this into the second or frontline setting, it may actually be relatively easy to use.
So there are two other studies that we'd like to talk about. One is presented by Federico Innocenti, and this is a study looking at genome-wide association studies in patients who are enrolled in the CALGB 80405 trial. You remember that trial was a randomization between dealer's choice chemotherapy and cetuximab or bevacizumab. 80% of the patients on that trial got initial FOLFOX as their chemotherapy backbone. And GWAS testing was done, which did identify several single nucleotide polymorphisms that looked to be of interest. But my conclusion about this is that this is preliminary data and not something that is going to be translated into practice in the near future. Paul, do you agree?
Yes, I would totally agree. I think it's very interesting because we're looking for markers of response, especially with anti-angiogenic therapy, and there's quite a few SNPs or single nucleotide polymorphisms that are shown to affect prognosis in a number of these studies. And in this one from Innocenti, there's this axin-1 SNPs that have been looked at, and axin-1 is a Wnt regulator, and it seems that if you have a G to A single nucleotide polymorphism, it reduces your survival. And so I think it's very intriguing, but I think it's not yet ready for general usage. And I think we're going to have to see a number of these markers being investigated and come up with some sort of prognostic plan based on a number of markers. So I think at the moment it's intriguing, it's experimental, and I don't think it's ready for general usage, but I think this may be the way to go for the future.
So the last study we'd like to talk about is one looking at tumor-associated macrophages. And this was a combined analysis combining data from the TRIBE and FIRE3 studies, first-line clinical trials in metastatic disease. There's been great interest at this meeting about checkpoint inhibitors, the role of immunotherapy, and trying to understand how the immune response and chemotherapy given with targeted agents intersect is something that I think we're going to learn more about in the next few years at ASCO. Paul, do you care to comment on this trial?
Well, again, I mean, this is similar to the last one we spoke about. This is another sort of intriguing type of biomarker controlling tumor-associated macrophages. And they look specifically at a series of 7 genes that control tumor-associated macrophages. And they show that single nucleotide polymorphisms of TBK1 that plays a role in regulation of NF-kappa B played a role in outcome. And that various polymorphisms, especially in this case an A to T polymorphism, had an effect on outcome. And I think my feeling is similar to the last study, that these results are very intriguing, but they're not yet ready for general usage.
So overall, I would say that this has been a very exciting ASCO in the field of colorectal cancer. Part of that is that we're learning to use angiogenesis inhibitors as well as EGFR targeted therapies in more innovative ways, and to understand how they best are interdigitated with chemotherapy. And then, of course, we're also learning about immune therapy and its potential role, at least in subsets of patients with colorectal cancer. So for Investigator Insights, this is Richard Goldberg and
Paul Ruff.
Thanking you for joining us today, and we hope that you've learned something from our conversations.
Thank you.